Hello, I'm Dr. Rahn Kennedy Bailey, Chairman of the Department of Psychiatry at Wake Forest School of Medicine. I would like to share a few best practices when treating patients of African descent. I'll use the term blacks during this talk to encompass both African Americans and more recent African and Caribbean immigrants. 13.2% of the U.S. population, approximately 42 million people, identify themselves as black, and another 1% self-identify as multiracial. Frequently, blacks are seen in crisis and hence in the hospital emergency room setting. This may explain why adult blacks are 20% more likely to report serious psychological distress than adult whites. They're also more likely to have feelings of sadness, helplessness, and worthlessness compared to adult whites. While blacks are less likely than whites to die from suicide as teenagers, black teenagers are more likely to attempt suicide than are white teenagers. Social determinants, including socioeconomic status, can affect mental health, and class and poverty are two which impact blacks. For example, adult blacks living below poverty are 2 to 3 times more likely to report serious psychological distress than those living above poverty. Blacks of all ages are more likely to be victims of serious violent crime than are non-Hispanic whites, making them more likely to meet the diagnostic criteria for post-traumatic stress disorder. Historical adversity, for example, slavery, sharecropping, segregation, along with other means of race-based exclusion from health, educational, social, and economic resources, has led us to socioeconomic disparities experienced by blacks in America today. In spite of progressive gains and reform in our society, racism lingers and continues to influence the mental health of blacks. Damaging stereotypes and attitudes of rejection have diminished in many ways, but their continued occurrence points to a tone within our culture that has quantifiable adverse consequences. Recognizing these historical and cultural constructs, there are several best practices to keep in mind when treating black patients. First, proper screening and follow-through with quality assessments that utilize a biopsychosocial model will help practitioners gather unabridged evaluations of their patients. This, in turn, will enable them to find the most appropriate diagnosis for their patients. Second, keeping talk therapy the center of all treatment paradigms from the start, and then providing consistency in care should always be fundamental considerations for all providers. Finally, offering an integrated care model that includes wraparound services is important in the holistic treatment of black psychiatry patients, many of whom find support within family, churches, and the community. Health disparities and stigma that surround mental health create barriers for patients and impede treatment. Within black communities, attitudinal barriers can prevent patients from even seeking treatment in the first place. Some of this apprehension is born from cultural mistrust that can be linked to the Tuskegee Project. This suspicion can also influence blacks' willingness to enter research studies, leading to underrepresentation. Perhaps more damaging, it can lead some blacks to be resistant to pharmacological therapies. The fact that blacks are overrepresented in prisons, 1 million of the total 2.3 million people incarcerated in the U.S., is another barrier we face. People of color account for 60% of the prison population, and while blacks only represent 14% of drug users, they account for 37% of drug arrests. This reality leads to real issues in healthcare regarding access, mental health, and quality care treatment. Treatment issues that must be addressed include the fact that blacks are overrepresented in inpatient treatment and underrepresented in outpatient treatment. This can be attributed to misdiagnosis and other issues like access to care. Access is a central part of contention when thinking about the care of black psychiatric patients. Often, communities are not equipped with adequate facilities and services. Having to seek treatment outside of the place where you live is an added barrier and provides for another layer of issues related to time, work, and transportation. Looking ahead, while Black patients may prefer Black physicians, only about 2 to 4% of mental providers identify as Black, meaning Black patients are likely to be seen by a provider from a different cultural and ethnic background than their own. Similarly, in research, there's a paucity of Black researchers and Black patients participating in research, which is problematic, as research is the basis for our evidence-based clinical practices. Finally, it is imperative that we continue to improve our screening and assessment processes. We have to take cultural issues into account while still providing a general level of consistency between our patients. Early and accurate assessments and diagnosis simply lead to better outcomes for all patients. Third, we must consider the saliency of our treatment models and their relative effectiveness for clients with respect to cultural differences. Please refer to psychiatry.org for additional cultural competency resources for providers. I'm Dr. Rahn Kennedy Bailey, and that concludes our introduction to best practices for treating Black patients.